So this photograph that we just took was reminiscent of when we were together here a little more than a year ago. The first, it was at that time the Intrabeam users meeting, but this of course is the first Target Collaborative Group meeting, and it's a privilege to serve as its president. When this group was assembled here, they shared a common view that there should be an enduring national or even international organization committed to advancing targeted intraoperative radiotherapy and adjunctive technologies with the overall goal of improving the effectiveness of cancer care as well as reducing the burden of cancer therapy. Now, they said that they wanted to elect a president, and they said we needed a president with tremendous intelligence, smarts, cunning, strength, and stamina. So the choice was obvious. and knowing how well our president is able to turn a phrase, I thought that this was appropriate for what we aim to do, which is to think big. As long as you're going to be thinking anyway, think big. So it is, for that reason, a real thrill to be here, a little bit more than a year later, having realized the formation of this national or potentially international organization and enjoying this first annual meeting. Now, none of this would have been possible without the tremendous effort of the board of directors shown here. Stephen Grobmeyer, surgeon; Richard Hoffer, surgeon; Sheldon Feldman, surgeon; Christine Laranga, surgeon; Andrea McKee, radiation oncologist; Barry Rosen, surgeon; Bill Small, radiation oncologist; and Valerie Yu, radiation oncologist, and also our secretary-treasurer. They have spent a tremendous amount of time, dozens of conference calls, thousands of emails over the course of last year to see this organization form and to put on this first meeting. And special thanks go to Andrea and Richard. Richard unfortunately could not be here due to other obligations, but that did not prevent him from working diligently to help put on this meeting. Of course, you've seen all the effort that Andrea has done here, but there were, again, many weeks and months of work leading up to this point. I also want to acknowledge other members of the scientific committee, Eileen Conley, Rooks Brooks Phillips, and also members of the board of directors who worked to make this happen. They tried to squeeze as much content as they could in a day-and-a-half meeting. So if you didn't see everything you wanted to see this year, come back next year and there'll be more. Now, from a financial perspective, this meeting would not have been possible without the support of our sponsors and our exhibitors. You see them listed here, and of course they're out in the lobby area. Do spend some time with them because we count on them to keep us financially sound. But I want to especially acknowledge our platinum sponsor, Zeiss, which has been with us from the very beginning, as many of you know. And I personally have had the opportunity to work with Jeff Rosbert over almost 15 years now, from the point of when I first wanted to join the TARGET trial and then ultimately joining the TARGET trial, and Bridget Both as well. They've been champions of the TARGET trial and of intraoperative therapy, and I really credit them for what we've been able to accomplish in this country. Now, the Target Collaborative Group is a cooperative effort between radiation oncologists, cancer surgeons, physicists, and other experts in intraoperative therapy that share a common commitment to improving cancer patient care through education, patient advocacy, mentorship, and collaborative research. We chose this as our symbol because it symbolizes both the challenges and the opportunities that we've faced over the years and that we will face. Now, you may recognize a resemblance of our logo to the International Radiation symbol. That was intentional because obviously the main modality that we're working with is a radiation therapy. But it also represents a target as well, both the target from the perspective of the Target International Society and targeted therapy as a means of providing focused radiotherapy to minimize the collateral damage of radiotherapy. But there's also the notion of a target, as in the target that has been on a number of our backs as we've tried to advance intraoperative radiotherapy. Now, the symbol itself, to be more precise, is a collective of the red being surgeons, the purple radiation oncologists, the green physicists and other professionals, and the blue is a patient at the center. So these specialists are working collaboratively for the benefit of the patient. But there's one other notion that I think of when I see that symbol, which is that of the hurricane symbol. This time with the physician and specialist at the center, surrounded by a storm of forces that are trying to resist this advancement. But I also recognize the hurricane symbol as a symbol of resilience because of this saying, which is that you can dance in the hurricane, but only if you're standing in the eye. And that's exactly where we've been for the last 10 to 15 years, led by visionaries such as Dr. Baum and Dr. Dia, and supported by a commitment to research, which we've all been involved in, and of course, guided by the data that the research has yielded. So I think this is really just further proof that we should feel confident in where we are and not be distracted by the controversy that may surround us. Now, sorry if you may feel accosted by these quotes, but I figured that I should share a few things from Mr. President. What separates the winners from the losers is how a person reacts to each new twist of fate, and we've experienced many of them over these years. And it really, if you're a student of history, you recognize that we have overcome many challenges in cancer care and medical innovation, and we'll encounter many others. But if we remain steadfast and committed to doing the work, we will overcome each new challenge. You saw this gentleman yesterday, Sir Geoffrey Keynes. He's a London surgeon who in 1924 performed the first lumpectomy and radiotherapy procedure. And that was at the time when the whole-state radical mastectomy reigned supreme across the country and certainly across Europe as well. So that was a radical move, but he and others saw that there was a possibility of changing the way that breast cancer was managed. And following decades of ridicule and resistance, it was finally accepted breast conservation as a preferred way of managing breast cancer, early-stage breast cancer. And I'm guided by a number of examples. I recognize that ridicule and resistance are the price of admission for being a price that we should always be willing to pay. So thank you for being. But ultimately, the story of Target is not about us, it's about patients. Patients that have challenged us to develop better ways in breast cancer, ways that are less burdensome. Us and their lives on the line to advance medical care for women whom they may never meet. So if you're frustrated by the challenges that we've experienced over the years, I think there's a lot of reason to be optimistic. Patients have reason to be optimistic, and so do we. We've experienced a number of accomplishments over these years that we should acknowledge in spite of the challenges that we face. If you're frustrated by the ASTRO consensus statement, which suggests that the target follow-up is too short, I say time is on our side. Given a few more years of follow-up, the results will be undeniable. If you're concerned about the provision that target should only be provided on registry, do know that the Target Collaborative Group is working diligently to establish a prospective registry that all providers across the country may participate in, with the goal of advancing Target as a standard of care for breast cancer, to expanding the current indications to other breast indications, and of course move beyond the breast to establish indications for Target outside in other parts of the body. If you're concerned, as I have been over the years, about coverage challenges, many of the people in the room, in fact, have spent many days and weeks traveling to Bethesda, Maryland, lobbying Medicare to prove and provide coverage for this. And in fact, the results of that effort is that all but one Medicare region in the U.S. covers the targeted intraoperative therapy procedure for breast. And thanks to recent work by Eleanor Harris, soon that last one I think will fall and we'll have nationwide coverage of Target. So thank you for your work, the work you've done and the work you continue to do. There's also the challenge with commercial payers as well, and thanks to some recent work by Barry Rosen, Bill Small, Blue Cross Blue Shield of Illinois recently announced coverage of Target. And as you heard yesterday in California, Anthem Blue Cross announced that effective May 18th, that Target would be covered for patients meeting ASTRO guidelines, or ASTRO consensus guidelines for IRT. That's women with invasive breast cancer under 2 centimeters, and women with DCS as well, up to 2.5 centimeters. You see the guidelines here, but these are basically right out of ASTRO's consensus statement. So that's a lot of progress, and as you know, as goes California, so goes the nation. So with your help, I think we'll soon see this as an option for women across the country. The other challenge, of course, we face, especially the surgeons among us, is that we've been, through passion and through interest in this technology, offering this treatment without reliable reimbursement. Certainly, we've worked over the years, I have and others, to secure reimbursements for hospitals, to secure reimbursements and CPT codes for radiation oncologists. Those have been accomplished, but I'm excited to know that within a year, largely thanks to the work of the American Society of Breast Surgeons under Sheldon Feldman's leadership, we now will have a CPT code that surgeons can use to bill for the procedure. So you should expect that in 2018. So we've accomplished a lot, but we can do so much more, and we can definitely do so if you join us. As you know, you've heard about research committees and outreach committee, the advocacy committee. We need support on all of these, particularly the advocacy committee, which is involved with society liaison activities, reimbursement, and insurance coverage. So join us today, but also join us as members in 2017 as we launch a membership drive later this year. Sorry. It's always good to be underestimated because you can make a lot of advancement without people noticing, and I think we have. I should use that as my transition slide because I think people have probably underestimated Dr. Baum over many years, and he's proven them wrong in many cases. It's a privilege in a moment to bring him up. Professor Baum is Emeritus Professor of Surgery at the University College of London. When I think of the TARGIT trial, I think that this baby had 2 dads, not one. One dad being Jay Vadia, the younger, more ambitious, and he said slimmer Jay Vadia on your left, and the more senior, erudite surgeon on the right, Professor Baum, who performed the first TARGIT procedure July 2nd, 1998. Professor Baum is, as you see, the Emeritus Professor of Surgery. He was a past chair of surgery at the University College of London, past president of the British Oncology Association, and past president of the European Breast Cancer Conference. He did pioneering research in quality of life assessment and tamoxifen research. He was the PI of the ATAC trial, which is the largest breast cancer trial conducted ever. He was the international PI of the Target A trial. As a Renaissance man, he has interests beyond medicine in fine arts, literature, and philosophy. He's published 3 books, one called The Skepticemic Surgeon, another The Final Tablet of the Holy Covenant, and the last one listed there, Breastbeating, One Man's Odyssey in the Search for an Understanding of Breast Cancer, the Meaning of Life, and Other Simple Questions. So obviously he's accomplished quite a bit. He has one other skill set that I wanted to share with you, if we could start the video. Video, please. Or not. Let's see if it plays. If not, we won't.
I think this is going to be hard to sense.
Okay. Well, it actually was a video of Professor Baum dancing. Well, there you go. Maybe. Well, just imagine Professor Baum dancing. And it was just to demonstrate that he really can dance in the eye of a storm. So, Professor Baum, please join me at the podium.